Welcome everybody to our 7th prolotherapy / platelet-rich plasma lecture. And this particular lecture is on treatment of the shoulder girdle. Our practical course will be in May on ultrasound-guided shoulder injections. So I have no disclosures. And before I go on or start this lecture properly, I want you to take a look at this particular picture, and you can see that they're trying to convey an impingement syndrome of the supraspinatus, causing a lot of pain. But there are several factors of shoulder function that are sorely ignored here. And this includes the fact that the scapula is not moving at all. The acromioclavicular joint is not moving at all. The clavicle is not moving at all, which means the sternoclavicular joint is not moving at all. And so 3 joints out of the 4 in the shoulder girdle are totally ignored. And if it was just this particular picture, then that would be fine. But the point is, though, that this is how so many of us physicians and many of the orthopods address the shoulder when they're treating it. They only address the glenohumeral joint. So if you want to aim high, by the way, this is a picture of my grandson dressing up for Purim. If you want to aim high and get good long-term therapeutic results, and you want to maximize shoulder function and range of motion, then you really have to do a very methodical, comprehensive evaluation and address the treatment accordingly. So you must understand that when there are stresses falling on the shoulder, it's not just on one little supraspinatus tendon, and it's not just on one joint or the acromioclavicular joint. It's on the region. Whether it's from trauma that happened in the past, which obviously you can't reverse those stresses because they're bygone, or faulty posture, or faulty ergonomics, the latter two which are continuous all the time, then these stresses affect the area, the whole region. And therefore, first of all, if you can possibly reverse the faulty ergonomics and the faulty posture, then that would be great, but it's not always possible. What we can do is strengthen the region so that that whole region will be able to withstand the forces that are applied to them. So we want to address the functional unit, and the functional unit in this case is not like a myofascial muscular functional unit where you have agonist muscles working in together, but I'm talking here of the rotator cuff tendons, the rotator cuff muscles, the surrounding joints, the ligaments, strengthening the capsule, and all the fibers are intermingling together, and not to ignore the neck. We know that neck pain and shoulder pain often go together, and one compensates for the other. And we must address the thoracohumeral muscles, because if they don't function properly, then we have a lot more stress on the glenohumeral joints. So we have to address all these together if we're going to have a comprehensive evaluation. And then treat accordingly. We don't necessarily have to treat everything in one treatment, and definitely not with prolotherapy or platelet-rich plasma. But if we combine the treatment with exercises, with ergonomic advice, with maybe physiotherapy, then and over a few treatment sessions, then this can maximize our therapeutic results. So there are several regenerative treatment types. Dextrose prolotherapy is the cheapest of all and the easiest to apply. Platelet-rich plasma, of which there are various forms. Today, there are new and new ideas cropping up every year with concentrated growth factors and concentrated cytokines, which we usually concentrate the anti-inflammatory ones. And those two are the subjects, the emphasis of these series of lectures. Bone marrow, aspirate and concentrate, fat injection in which we use the mesenchymal stem cells, ozone therapy, amniotic fluid, and exosomes. So the lecture is going to be based on, first of all, the basic anatomy and the biomechanics, important biomechanical structures and why we should treat them, various clinical conditions, commonly ignored predisposing shoulder pathologies. And this is so important because if we don't address these shoulder pathologies, then we will not get a maximal therapeutic result. A very quick look at the literature. A few ultrasound pictures. This is definitely not an ultrasound lecture that we're going to be giving at the course, but just to sort of whet your appetite a little bit, give you a glimpse of what we can see under ultrasound, and simple exercises to prescribe. And these address the predisposing shoulder pathologies. So the shoulder has a lot of challenges. First of all, it is the most mobile joint in the body, but this comes at the expense of stability. The humeral head is much larger than the glenoid fossa, so there's a 3-to-1 ratio in the surface area between the humeral head and the glenoid fossa. The glenoid fossa is much shallower, and therefore the humeral head sort of hasn't got the same stability and protection as, for instance, the acetabular labrum area, which really protects the femoral head. And also we must consider that there are 4 joints in the shoulder girdle which function together, and any dysfunction in one of these limits the others. So the range of motion of the different joints in the shoulder girdle. The glenohumeral joint here moves 120 degrees into abductional flexion and 80 to 90 degrees in lateral rotation. There are 6 movements, but I'm not going to go into each one of every movement of every joint here. The scapulothoracic joint here, it's not a classical synovial joint, but it does function as one. And this is very critically important to maximize the shoulder function, because the scapula contributes 1/3 of abduction. The scapula abducts 60 degrees when the shoulder abducts and flexes. It goes 60 degrees into abduction and upward rotation. There are 8 movements of the scapula, which I'm not going to discuss now. It's very complicated. This is a mistake here, Z and all that. The acromioclavicular joint here also has range of motion of depression and elevation and rotations. And the sternoclavicular joint here elevates and depresses, protracts and retracts, and has axial rotation. So if you can imagine, I've just explained how the scapula contributes 1/3 of shoulder abduction and flexion. So if you have an acromioclavicular joint, which is stuck or very, very severely osteoarthritic with limited range of motion, that acromion is not going to move sufficiently. It's going to move less than normal. And if it doesn't move as much as normal, the scapular movement will be limited. And if the scapular movement is going to be limited, you're not going to get 60 degrees of scapular abduction, which means you've got a much higher burden placed on the rotator cuff tendons and muscles to achieve maximal range of motion. Now, if the sternoclavicular joint is stuck, or it's not moving sufficiently due to some injury or whatever, then the clavicle is not going to move enough. And if the clavicle doesn't move sufficiently, then that's going to affect the acromioclavicular joint, which in turn will affect the acromion and the scapula and so on. So this is just to emphasize how much we need all 4 joints of the shoulder girdle to maintain and to achieve perfect function. So here is just a clip just demonstrating abduction and flexion. You can see the sternoclavicular joint move and the acromioclavicular joint move, and it shows you in all planes. adduction and abduction, and you can see that the tip of the scapula is meant to reach the mid-thoracic line, just here. And that's how you can check if you have perfect optimal scapular adduction. So looking at the anatomy of the shoulder joint, coming in from the lateral side, looking in on medially, you can see the glenoid fossa, which is very relatively flat and shallow compared to the acetabular fossa. And surrounding it is the glenoid labrum, which increases the contact surface of the humeral head by up to 50%. The labrum protects the glenoid fossa. It increases the surface area. It protects also the humeral head, and it adds stability in terms of damage and injury. And also to the glenoid fossa, the glenoid attaches the glenohumeral ligaments and the long head of the biceps. You can see here from the anterior aspect, the shoulder capsule. And you can see that the capsule inferiorly is sort of loose and baggy. So that's when the shoulder is adducted. So that when the shoulder abducts and flexes, then that has room to stretch so as not to limit range of motion. Now looking from the anteriorly at the shoulder joint with all the ligaments and capsules, etc. These ligaments here, glenohumeral ligaments, cover the capsule and reinforce it. The capsule is weak and thin, especially anterior inferiorly. So these ligaments are very important to strengthen the capsule. And the fibers actually interconnecting into one and are very much intricately connected with the capsule. So in this particular diagram, you can see that the ligaments basically cover the whole of the anterior surface. So with the superior glenohumeral ligament, the middle glenohumeral ligament, and the inferior glenohumeral ligament. This one is the largest and the strongest and the most important in terms of stability. And it's very important in terms of preventing dislocation of the humerus, because when you have a dislocation, it usually dislocates anteriorly and inferiorly. So this must be strong to prevent that. The coracoclavicular ligaments are also very important. And I've noted that people with previous history of dislocation suffer from this pain here, but I'll talk about that later. And here is the coracohumeral ligament, which is very important. It's related particularly to the rotator cuff, but also to the capsule, and we'll go into that later. So here is another picture diagram depicting the glenohumeral ligaments, and here they are depicted as just thin slivers of collagen tissue which reinforce the capsule. It's probably somewhere between these two diagrams, this one and the previous one, but what is for certain is that the fibers just aren't limited to just these thin slivers. Everything interconnects and everything's connected to each other and spreads out and forms together, combines with the fibers of the subscapularis and the transverse humeral fascia, and it just, everything very much merges in together. So everything is related and everything reinforces the whole structure. And here again is the coracohumeral ligament. When we're looking from the lateral inside, medially at the glenoid area, you can see the glenohumeral ligaments. This is the superior glenohumeral ligament. The colors are the same, so as not to confuse you. This is the middle, and this is the inferior. You can see that the inferior ligament is the longest and the biggest, and it's actually the strongest. And you can also see that it has a posterior attachment, which is very important. Here is the biceps tendon, which inserts onto the glenoid. And here is the coracohumeral ligament, which goes off on a tangent because it's inserting onto the coracoid process, as the name implies. So I've said all that. Now, the coracoclavicular ligaments are also important, connecting the coracoid process with the clavicle. Yeah. This is the coracoacromial, and these are the coracoclavicular. Yeah. So particularly with people who have had a history of dislocation of the humerus, because the chances are that the coracoclavicular ligaments were also damaged. And I find very often that people who've had a history of dislocation of the humerus and still have persistent pain, and even if they've had surgery, they have a lot of tenderness in this region, and they really improve when I inject these areas with prolotherapy or platelet-rich plasma. Also the coracoacromial ligaments. So this is very important and a very common source of pain. The sternoclavicular joint, just a couple of words about this. The sternoclavicular joint is stabilized by the anterior and posterior ligaments here. Mainly, there are several other ligaments. The sternoclavicular joint is formed by the manubrium of the sternum, the clavicle, and also the first rib here. And bear in mind that the sternoclavicular joint is the only joint that connects the upper limb with the axial spine. So the forces and truths transmitted through the sternoclavicular joint to the spine. The acromioclavicular joint permits scapular abduction, which takes 1/3 of the shoulder abduction. Now, the rotator cuff muscles, we saw before that the ligaments of the shoulder, the glenohumeral ligaments, cover the front of the shoulder joint. And there's little in the posterior. There's the inferior glenohumeral ligament coming up to around here. But basically, the glenohumeral ligaments don't go more superiorly. So to compensate for that, this is where the rotator cuff muscles come into play. So here we have the subscapularis anteriorly, and here posteriorly we have the supraspinatus, the infraspinatus, and the teres minor. So you can see how everything comes into play and is very much interconnected. So looking at the rotator cuff muscles posteriorly, you can see the supraspinatus, the infraspinatus, the teres minor. Now we know that the pull of the deltoid the delta has a relatively strong muscle, and it pulls the humerus up superiorly. So if you have rotator cuff failure and a massive tears of the rotator cuff, then you've got nothing to really pull the humerus down and towards the glenoid. So this is the importance of the rotator cuff muscles. The infraspinatus, where it's sort of aligned here, is you can see that it has a net pull, pulling the humerus and butting it to the glenoid fossa. So its force is to pull the humerus medially, but also slightly inferiorly. And by the way, the same with the teres minor. The supraspinatus, as you can see, pulls medially and superiorly. But because the supraspinatus goes further medially than the other muscles, it has a longer line of force, and therefore it's a lot stronger stabilizer than the other ones, even though it's a smaller muscle than the others. So, and the subscapularis again pulls medially and also slightly inferiorly. So all these muscles work together to abut the humerus against the glenoid, with 3 or 4 of them pulling it down, but the supraspinatus compensates by pulling slightly superiorly. Now, the importance of the rotator interval, I'm stressing again and again how much the tendons and the fibers and the ligaments and the capsule and everything is important, functioning together. So the rotator interval is the area between the greater tuberosity and the lesser tuberosity, and everything in between. So here you have a cross section. This is a picture taken from Joel Baumgartner's manual, which I'm going to show you in a second. This is the Supraspinatus tendon inserting onto the greater tuberosity. And here is the subscapularis inserting onto the lesser tuberosity. Now, overlying this whole area is the coracohumeral ligament that I've mentioned so many times. So here you have the lateral band of the coracohumeral ligament inserting onto the greater tuberosity, and the fibers are intermingling with the supraspinatus tendon. And the coracohumeral ligament overlies this whole thing and provides some sort of stability in holding this whole thing in place. And the medial band of the coracohumeral ligament inserts onto the lesser tuberosity, and the fibers intertwine with those of the subscapularis. Now, underneath here, you have a long set of biceps, and you have the superior glenohumeral ligament inserting into here. So everything is interconnected. Now, what happens when you have a tear of one of those? If let's say you have a little tear of the superior glenohumeral ligament here, then the next stage is you've already got some sort of loss of function, some sort of start of instability here. So the next stage you can have a supraspinatus tear here, or a subscapularis tear, or both together. So this is, by the way, this is the picture of his manual, Baumgartner's level 2 with ultrasound. I'll bring that to the course if anyone's interested. So you can understand how all these structures together function together. And if one structure is not functioning well or is slightly torn, then it's already a precedent for further tearing and wear and tear and dysfunction. Pain referral patterns from the rotator cuff. Now, I must say that I have no pictures of referral patterns from the rotator cuff tendons. These are pain referral patterns from the rotator cuff muscles, from trigger points of the rotator cuff muscles. Supraspinatus refers down to the wrist, supplied by C5. And most people feel the pain around the shoulder, but it can radiate down to the wrist, but anteriorly and posteriorly. Anteriorly slightly less. The infraspinatus radiates past the wrist, or can radiate up to including the thumb and to the lateral 2-3 fingers. And that's logical because the infraspinatus is supplied by C5-6. And the subscapularis, interestingly enough, can refer pain around the shoulder up to the elbow, skips the forearm, and causes pain in the wrist. So if someone has pain in the shoulder up to the elbow and also pain in the wrist, think of one of the differential diagnoses that that patient may have a subscapularis problem. Now, the only textbook I have seen that has any mention of rotator cuff tendons causing pain down the arm up to or past the wrist is James Syriac's textbook of orthopedic medicine, which was written in the 1980s. I don't remember any pictures of those referral patterns, but and I haven't got this book anymore. I don't know where it's disappeared. It's lost. But I can tell you from experience, patients often complain of pain down the arm, and the differential diagnosis is neck pain. Both have to be evaluated clinically, very methodically. But I can tell you that treatment of the shoulder tendons often cause relief, lead to relief of this pain radiating down the arm. So referred pain down the arm does not equal radicular pain, in exactly the same way as with the lower back and the sacroiliac area. So rotator cuff tears are the most common cause of pain in the shoulder, causing a lot of morbidity, and between 50 to 67% of tears are asymptomatic, which makes you wonder what are the causes of actual pain? Are there any other factors that cause the pain? And if a patient has all of a sudden begins to feel pain and weakness, even in someone who has been asymptomatic until now, one should suspect a tear or enlargement of a tear. One may get reduced range of motion on examination, and usually this will be a reduced range of abduction. This will be limited, usually. A differential diagnosis of this whole condition is adhesive capsulitis, in which, first of all, the history is different. You have a history of pain, and then slowly the pain, as the pain starts to subside, you get a freezing of range of motion, frozen phase, and you have some sort of overlap in that time. And then afterwards, you have a thawing out phase. And with adhesive capsulitis, what you classically find on examination is limitation of lateral rotation in relative terms compared to abduction and flexion. And overall, between 47 and 52% of tears can progress in size. So that's why it is important to treat these tears, especially particularly the partial tears, but even the full thickness tears, and I'll explain that when we get onto that. So when we're talking about tear size, when we classify in tear size, we're talking about small tears, as in less than 1 centimeter in either length or width, medium-sized tears between 1 and 3 centimeters in length or width, large tears between 3 and 5 centimeters, and massive tears of more than 5 centimeters. So I'm going to explain to you what the bursal-sided tears and the articular-sided tears are. When we get to the ultrasound, I'll show that to you. But the bursal-sided tears occur more often in younger people who are sports active, throwing overhead and swimming. And the bursal-sided tears and the medium-sized tears of 1 to 3 centimeters are the most at risk of progressing and enlarging. And the full thickness tears, the 1 to 3 centimeter full thickness tears, have the increased rate of progression of the tears. If the tear is 50%, more than 50% of the thickness, of the depth, which I'm going to show you, then they also have an increased risk of tear progression. So here we're talking about a 3-dimensional tear. We're talking about the depth, we're talking about the length, and we're talking about the width. The length here and the width here. So there's 3 dimensions: depth, length, and width, that way. So this is all from these journals. We know that when we have rotator cuff failure, you have the net pull of the deltoid pulling the humerus up, and gradually that humerus is the tendons are going to rub against the acromion more and more, and you get more and more rotator cuff failure, and eventually rotator cuff arthropathy. And this has been shown to be, there has been shown to be a clear association between the rotator cuff failure here and rotator cuff arthropathy with rotator cuff tear size. So our role is, we can't strengthen the rotator cuff tendons when the tears are massive, but we can try and strengthen the glenohumeral ligaments as much as that can contribute and make them feel better. It's not an abracadabra, and many of these patients will need surgery if they've got rotator cuff arthropathy. The last condition I'm talking about here, just have a look at this picture and see what that patient has. Spot diagnosis. So you can see here the edge of the shoulder is sort of squarish. I haven't got the other shoulder here to compare, I'm sorry. But you can also see that there's a bit of swelling here. It's kind of a round sort of lumpish sort of thing. So this guy has an anterior inferior dislocation of the shoulder. And these occur particularly in young people who are active with high demand contact sports, their increased risk with dislocating the shoulder is with a previous dislocation, and if they're hypermobile. And as I said before, most of the dislocations are antero-inferior. The shoulder capsule is loose, large and weak in order to allow range of motion, particularly anterior-inferiorly, it's weaker, and this is strengthened by the inferior glenohumeral ligament and the rotator cuff tendons. So muscle imbalance is leading to shoulder pathology. This is very important. And I want you to have a look at these and see if you can make a spot diagnosis as to what's going on before I give you the answers. I've given this away, this one and this one. So in this chap here, he's got adducted scapulae, and they're high. So this is due to an overactive middle trapezius muscle and an overactive upper trapezius muscle. So this chap is going to have possibly more strain on abducting the scapula. Maybe yes, maybe no, because the upper trapezius elevates the scapula. But whatever the case may be, he's putting more strain on the rotator cuff here. This chap has abducted scapulae, and importantly is that his shoulders are very much medially rotated. His palms are facing posteriorly. And this is really common amongst people who lead a sedentary lives. They spend all the days in front of the computer like this with their shoulders rubbed forward. This woman has downwardly rotated scapulae, and the right scapula is lower than the left. The right shoulder is slightly lower than the left. She complained of right-sided sort of scapular pain. So you can see that her rhomboids are dominant here, causing downward rotation of the scapula. And either her levator scapula here is also dominant because it elevates the scapula more than the right-hand side, or that's normal and this has to be, and this just got more downward rotations of the rhomboids here. You have to, that's a differential diagnosis here. This woman has not got a lipoma here because when I'll show you the other side, she has exactly the same swelling here. But you can see that both scapulae are very much anteriorly tilted. And this has a huge significance on the shoulder function. So three phenomena to often ignored. One, the scapula contributes to 60 degrees of shoulder abduction. And if you have limited scapular abduction, you're going to have more strain applied to the rotator cuff to try and achieve full shoulder movement. Now I want everybody to stand up. Everybody's going to stand up now. And everybody in front of the computer, you're going to standing in front of the computer, and everybody is going to abduct their shoulders to full range. Now I want everybody to stand sort of really slouched, really slouched, thoracic kyphosis, medially rotated shoulders, palms pointing backwards posteriorly, okay? This is to exaggerate the concept that I'm trying to teach you now. And now abduct your shoulders as much as you can and see what range you can get up to. And now I want you to straighten up, arms beside your hips, your thighs, and abduct your shoulders. And what you'll notice is that as you abduct your shoulders, as you get to about 90 degrees of shoulder abduction, you will notice that your shoulders automatically laterally rotate. And this is God's present to us, because as we laterally rotate our shoulders, our supraspinatus is escaping the acromion. And therefore, we're minimizing the attrition there of the acromion on the supraspinatus tendon. So people who have medially rotated shoulders are more at risk of wear and tearing their supraspinatus tendon. So this is why it's so important to address the whole area. Now, this lady with the anterior tilted scapula, you can see that also the right scapula has this sort of swelling here. And you look at this is caused by a dominant, short, contracted pectoralis minor. The pectoralis minor, we know, connects to the inserts on the coracoid process. And if the muscle is short, it's going to pull on the coracoid process forward. And if it pulls on the coracoid process down, then it's going to also pull the acromion down. And if it pulls the acromion down, you're going to have less space here for the supraspinatus tendon, and you're going to have more wear and tear. So that's why it's very important when you see someone like that, and it could be that she's got a thoracic kyphosis as well, but that could be secondary to the scapular movement position. So we should try as much as possible to get these people to stretch their pectoralis minor, and one has to do this religiously. And I'm going to show you that soon, or a little bit. I'll show you where to find it. Okay, so a little bit about the literature, not too much. Two studies. One, this was a meta-systematic review on different injection therapies for rotator cuff tendinopathy, showing that steroids are good, but only for the short term. Both prolotherapy and platelet-rich plasma were effective in the longer term, more than 24 weeks. This was a systematic review on partial rotator cuff tears on PRP injections and compared to other sorts of treatment. Platelet-rich plasma was superior in the long term, in terms of pain and function. In the short term, only in terms of function. Now, in the very short term, this is actually very understandable because platelet-rich plasma or any regenerative treatment takes time to take effect. It takes time to build collagen tissue, and it takes time to heal. So at the beginning, it does cause a little bit of pain. And in the short term, you're not going to necessarily see any difference between platelet-rich plasma and other therapies such as steroids. But in the longer term, prolotherapy or PRP, here this study was done on PRP, showed that this was much more effective, both in terms of pain and function in the long term. Now, there are many studies that have shown that platelet-rich plasma is not more effective than other treatments that they've done. And I think this is because they're not using the comprehensive approach that we use with prolotherapy that I'm teaching here. Because if you're just going to treat the supraspinatus tendon in exactly the same way that orthopedic surgeons will repair the supraspinatus tendon, they'll find that you have a certain re-tear rate. Often pathology comes back or in other areas. But if you're only going to address just one structure without addressing the whole functional unit, then you're not going to necessarily get a long-term outcome. And I think, personally, I think this explains why a lot of this literature that was studied on platelet-rich plasma was not that, did not show any difference between that and other therapies. Also, platelet-rich plasma literature wasn't necessarily homogeneous until a couple of years ago. There weren't clear definitions. Now the journals are starting to demand that if you're going to do a thorough platelet-rich plasma study, you have to define, is it platelet-rich, platelet poor? Is it white cell rich or white cell poor? Is it with anticoagulant, without anticoagulant? Have you got a calcium or thrombin added to cause the blood to coagulate? And all sorts of definitions, you're going to define how to rate your categorize your platelet-rich plasma treatment. So now that we've finished examining the shoulder, which I haven't talked about here because that's a lecture on its own, and we want to palpate the supraspinatus tendon, or we want to expose the supraspinatus tendon to see it under ultrasound or to inject it, we have to do a particular maneuver because the supraspinatus is covered largely by the acromion. And so in order to expose that and bring that out more anteriorly, you have to ask the patient to medially rotate his shoulder. So by the way, this is a gentleman who volunteered to give me his beautiful portrait. So he's medially rotating his arm. This is the clasp position where he's got his hand on the opposite pocket. And this is the clasp position. But the disadvantage with this is that a lot of the patients with rotator cuff problems have a lot of pain when they medially rotate and when they put their hands behind, and they just cannot get to that position. So we use often what's called the modified clasp position, where he puts his hand on the ipsilateral hip or pocket, back pocket. And this is what you get. You get a exposed supraspinatus tendon over here, and that's easy to palpate. So what structures to inject for rotator cuff tendinopathy or partial tears? To inject the tendon involved, preferably also the nearby tendon, and sometimes even all three tendons. I rarely inject the teres minor, but sometimes I do. But at least these, so the supraspinatus and the subscap, or the supraspinatus and infraspinatus, depending where the teres, at least. And also the rotator cuff interval. So when I'm injecting this, I will usually come in laterally. I'll inject some of the fibers of the supraspinatus, bearing in mind that I really want to see the supraspinatus well in this position that I'm injecting this with the hand supinated in front. Then I'm going to aim for the lateral band of the coracohumeral ligament. I'm going to aim for here. And then I'm going to go to the superior glenohumeral ligament attachment more medially, and I'll pull out, not completely, and then I'll go to the medial band of the coracohumeral ligament here, and I'll pull out and not pull out completely, and then I'll go to the subscapularis insertion. So I have done 5 injections here with just one jab, and this treatment adds tons to our therapeutic results. So here you can see that here's the supraspinatus insertion, the subscapular insertion, and the rotator cuff interval, and here is posteriorly the infraspinatus insertion. It'll be more lateral. So on the bone here, this is the lesser tuberosity, the greater tuberosity, the rotator interval just on top of just before the bicipital groove actually starts. And here is the insertion of the infraspinatus, actually probably a little bit more this way. So recurrent dislocation, what would you inject? So the most important is the inferior glenohumeral ligament, and to try and get to both attachments. To inject the coracoclavicular ligaments, possibly the coracoacromial ligaments. Some of these patients may need surgery. I have had quite a few patients who have had surgery who have suffered catastrophic adverse effects with damage to the brachial plexus. So I firmly believe if you can prevent recurrent dislocation with some sort of regenerative injection therapy, then go ahead. For massive rotator cuff tears, rotator cuff failure, rotator cuff arthropathy, we can't do a huge amount. A lot of these patients may go for surgery, although a lot of them are elderly and a lot of them have comorbid pathology with other heart problems and cerebrovascular disease and so on. So you have plenty of patients who are unable to undergo surgery. So I will inject the inferior glenohumeral ligament attachment, both sides. do an intra-articular injection. And this often results in a lot of relief of pain. Temporary, I must say, but it does add quite a lot. And for some reason, the improvement seems to be out of proportion to the to what I've injected. Some people really make amazing improvements in function. Also, nerve blocks to the suprascapular nerve, to the axillary nerve, various pain procedures, pulse radiofrequency, and so on, and arthroplasty. Okay, so what does it look under? What do the tendons look like under ultrasound? So here is a normal, beautiful ultrasound picture. This actually should be sort of black, but it's not. This is an ultrasound picture of the gentleman you saw before who posed for me for the modified crest position. So here is the greater tuberosity here, the footprint, and here is the humeral head, and here are the parallel fibers of the supraspinatus. It's really beautiful. Here is black, not because there's a tear, but because the fibers coming in from another angle are not perpendicular to the probe. But if you toggle that probe in a different direction, then that'll come out white and other areas may come out black. So that's the way to check that it's not a tear. And this is the longitudinal view. So you will have the probe facing this way. It's sort of in line with the line of the humerus towards the ear. If you turn the probe around 90 degrees towards the nipple, so before it was this way, then this is what you're going to get. This is the supraspinatus here. So it's a short axis view. Now, types of tears. So I mentioned before, okay, so this is the same guy's ultrasound picture we saw before. So this is the greater tuberosity, and here is the bursal side of the superficial side of the supraspinatus, and here is the articular side. Now, a tear that can either be full thickness tear is defined as a tear that goes through the whole depth, from the articular side all the way up to the bursal side. It has no reflection on the size of the tear, on how wide it is and how long it is. So a tear can be 1 or 2 centimeters long this way. It could be 1 or 2 centimeters long, sort of going along the width. If you sort of imagine that this is successfully has lots and lots of images like that, parallel to on either side, in front and behind this image, in other words, looking at the transverse view, then you can have a tendon tear that's 1 or 2 centimeters wide, both wide or long, but it can still be a partial thickness tear. Okay, so if you're going to go back to, 1 second, here, this picture here, if you can imagine, you can have a tear that's sort of like, okay, long this way, 1 or 2 centimeters long that way. It could be 1 or 2 centimeters wide this way, but it doesn't necessarily have to involve the whole depth of that tendon. Okay, so an articular sided tear, which is the type that you get in the elderly, is where, as the name implies, the tear is closest to the articular cartilage. A tear over here on the footprint is not considered part of the tear. It's sort of tethering of the fibers, but it's not classified as part of the tear. So here it's got to be touch the cartilage here. This is the articular side, and you can see it doesn't go the whole depth. The bursal tear is, as the name implies, is closer to the bursa. Now this is I've sort of drawn it artificially. That's where a bursal tear would be. So what usually happens is you sort of get a dip in the superior or the superficial line of the of the supraspinatus tendon, and you get a bit of inflammation here on the bursa. So you usually get a bit of bursal swelling here, edema. Now, the bursal-sided tears have a much poorer prognosis than the articular-sided tears, and these are the ones that occur in the elderly, interestingly enough. This is the subscapularis. It's a longitudinal view, so if you're looking, the subscapularis is coming across from the scapula, which is behind the thorax, so it's coming across to insert onto the lesser tuberosity. So if you're holding the probe transversely, this is actually a longitudinal view of the subscap. This is lateral and this is medial. So over here, this way is going to be somewhere the coracoid process there. And here is the infraspinatus. This is looking from behind. You're looking just under the spine of the scapula. And here is the cartilage. Sorry, this is the humerus. And this is the black area is the cartilage here. Okay, and here is the musculus tendinous junction here. And here you have very nice parallel fibers of the infraspinatus. And they're sort of going towards the insertion. It's going to insert on the lateral facet of the greater trochanter, which you can't actually see here. Here is the glenoid. And here is the labrum here. So if you want to inject intra-articularly from the posterior aspect, you could just put your needle just here and fall short of the labrum so as not to damage the labrum. So I'm just going to present a few of these pictures from patients of mine. Anecdotal, very anecdotal evidence of some sort of experience of improvement of the healing of partial tears with prolotherapy, with dextrose prolotherapy. So this is these are scans of a guy who, a 33-year-old guy who was worked as a guard in one of the villages close to me. He was shot by a terrorist, which is not an infrequent occurrence, unfortunately, in this country. And you can see here that the bullet went through the supraspinatus tendon. It came out through the infraspinatus tendon. It tracked along the back of the scapula and landed up behind his cervical spine. It's quite amazing. But anyway, this, you can see a fracture here on the greater, just the medial side of the greater tuberosity here. And here is a sort of a tear here, you can see, which goes up to sort of here. Not all the way, it's a partial thickness tear going up to here and a bit here. So that is a partial thickness tear. I can't remember how long and wide this tear was. And if you're looking at cross section, so that was taken, the longer section is taken from this angle here, and now the cross section is going to be taken from this angle. You can see that the tear, you can see the bony fragment here. So underneath it's anechoic here. And you can see the tear sort of going, it actually seems to extend more. It's almost, looks almost full thickness here. So he had 2 prolotherapy treatments a month apart. And here you can see it's not exactly the same place, but you can see that there's some sort of healing of the fracture here. And the tear seems to be filled up with organized, it's starting to organize. The collagen tissue is starting to organize and heal. And here also, this is exactly the same area as before. Here's the fracture is starting to heal. By the way, he started treatment 6 months after the bullet injury. So here is the fracture is starting to heal, and also the tear is starting to fill up with organized collagen tissue. This is a chap who had a 65-year-old guy who had a tear of the 9mm tear of the subscapularis, not by a bullet. You can see that, and after treatment, his tear is starting to fill up with collagen tissue. Is the coracoid process here and here. So that is the longitudinal view of the subscapularis. Now, I've mentioned and stressed how it's important to treat the whole region and to address the other areas. So if a patient has tight scapular muscles and the scapula is not abducting sufficiently, then we need to release these muscles. And you can do this very easily with dry needling, and you get a response within seconds, really. By here, I'm needling the rhomboids, and you can go on to needle just at this area, the levator scapula. This is an amazing treatment. Here I'm needling you can't really see exactly where this is, but you've got to do this very carefully. It's the upper trapezius. You've got to do this very carefully so as not to cause a pneumothorax. And here also. But this is an example of other treatments that we can use. And dry needling goes fantastically together with prolotherapy or platelet-rich plasma. It really does. So the infraspinatus, we talked about people with medially rotated shoulders. And we want to strengthen their infraspinatus, and specifically their infraspinatus. Because if you go to the gym and you see the people are doing this sort of exercise, if you feel your scapula, you can feel that medially, you can feel that rotating. So you can feel that the rhomboids are working here. But you don't want to strengthen the rhomboids. You want to strengthen specifically and selectively the infraspinatus tendon. So what I recommend is, this is an exercise recommended by Professor Simon, a physiotherapist in St. Louis. So emeritus professor of physiotherapy. So you abduct the shoulder to 90 degrees. You flex the elbow to 90 degrees like this, and you lift the shoulder you lift the hand up. And I recommend patients to take a kilo weight of, let's say, even in the house, a kilo of flour or kilo of sugar, and to sort of do this. And I sort of ask patients as I see them in the corridor, wherever I see them, if they're doing the flying exercise, and they're sort of flapping their wings. This is a great exercise, and patients really feel that they're strengthening their whole region with this exercise. The second exercise is release of the pectoralis minor. Now, I stressed this before, that this exercise has to be done really religiously. If someone has short scapula and they're starting to move towards a thoracic kyphosis, they have to stretch their pectoralis minor daily, a few times a day, or one exercise done a few times. I'm not going to show this video here because it takes 10 minutes. There are lots of videos on the internet, on YouTube, how to stretch the pectoralis minor. Make sure that you're doing the pectoralis minor and not pectoralis major. It's a different exercise. But that's really important for patients with anteriorly tilted scapulae. So in summary, if you can come across with just these points you've gained from this lecture, your treatment, you will reap much better long-term results if your treatment follows a methodical clinical assessment. If you address contributing postural factors, if you consider that multiple pathologies may coexist, and if your treatment addresses the whole functional unit. So thank you for listening. I'd love to see you at our course, practical course in May. If you have any questions, you can contact me here, or and the course is here in Israel, in Asafar Fair Hospital. So be well, and I hope to at least see you in future lectures.